Victory, a reproductive endocrinology and infertility specialist, board certified in Canada and in the United States. We have a special show today because I am on holidays. And so instead of doing a live, we thought we'd answer some of the questions we've missed in previous episodes and record it and play it back for you guys at a later date. So Tarek is here with me and he's going to be asking the questions and I'll do my best to answer them as usual. Tarek, fire away.
All right. So questions from the previous show. We'll start with that. Hi, Dr. V. Will a Lupron depot have some long-term impact for DOR patients? Thanks.
Yeah, so in theory, it shouldn't, but it's not something we generally use for DOR patients unless they have endometriosis. So in patients with endo, you kind of have to use the Lupron because you want to suppress the endometriosis. But in anyone who does not have endometriosis, we would probably shy away from it just because it is going to suppress the ovaries. And you really need the ovaries to be maximally unsuppressed when you have DOR. So we try and avoid it in anyone other than an endo patient. If it is being used in an endo patient, we would only use it after we've produced embryos and in preparation for a frozen embryo transfer.
Hi, Dr. V. We are so excited to see you soon. Can you share your thoughts on acupuncture for FET? And do we have sex the night before the FET? Thank you.
Yeah, so acupuncture is a great big question mark in the fertility world. There are studies that show that it is not beneficial, studies that show that it is beneficial. And of course, there's this one very funny study that showed that the placebo, which was just tapping with a blunt needle, was actually more successful than the acupuncture. So we really don't know. What we generally tell patients is that if it helps relax you, you're probably going to get some benefit from it. And if it doesn't help relax you, then there's probably no advantage to doing it. So as a general rule, we try and tell patients to use it only if they think that it's going to help calm them down and bring them that sense of well-being and sort of fulfillment that acupuncture can bring. Otherwise, it's probably not of huge value. As far as sex is concerned, we do know that the ejaculate can actually prime the endometrium to help increase your chances of success. So not only should you do it the night before, you should really be doing it frequently before in order to maximize your chances.
Hi, Dr. V. Just wondering, what are the ways to increase progesterone naturally?
Well, there really aren't any ways to increase progesterone naturally. Your progesterone level is 100% dependent on the release of your corpus luteum and the quality of the egg and how strong it is and how many eggs you release. So you can't really adjust that naturally. There are natural sources of progesterone like yams and so on, but you can't increase your body's own progesterone naturally. There's no control over that.
Dr. V, do you think calcium ionophore always has positive outcomes in IVF?
Yeah, so there's literature for and against calcium ionophore. So there is data that suggests that in cases where you've had previous failures, previous poor fertilization or blastocyst development, the calcium ionophore treatment of the eggs can actually improve the outcomes. There are also studies that show that it was not beneficial. I've never seen one that shows that it's harmful, but there are studies that show both a positive and no effect. We do use it. We use it in the cases where patients have previously had bad outcomes. And I actually do think it makes a bit of a difference. So we've been using it quite a bit. And if you watch our Instagram posts, you can see we have loads of success where others have failed. So I think part of that is the calcium ionophore. It's only a small part. We have a lot of tricks and tips and things that we use for our patients, but the calcium ionophore is one part of that.
Can you explain all about the process of LH surge, high versus peak? Does the timer process start when you reach your peak for ovulation to happen after that? I'm just confused.
So I don't know if I can explain all about it, but I can give you as much information as this sort of format allows. So the LH surge occurs when your brain recognizes from estrogen feedback that it's time to release an egg. The surge itself is not like a sudden spike. It actually takes kind of 24 hours to begin rising. hit its peak and then release. And sometimes the duration of the surge can actually be prolonged. So most people have a very short spike time of that 24 hours, but other people can be up to 48. And I've seen reports of even up to 72 where you have these high maintained LH levels. So it can vary from patient to patient. As far as the actual, relationship to things and when are you releasing your egg, we anticipate that somewhere between about 18 to 24 hours after the peak level, you should release your egg. So that's kind of what we use as our marker or our time frame for doing things like insemination or even timed intercourse. But it's really hard to figure out what that is when you have a prolonged peak stage. So if you're like a 48-hour, the key is to just make sure that you're having intercourse every day, because remember, the ejaculate or the sperm can live inside you for up to 3 days. So it's entirely possible to have sex, for example, yesterday, release your egg today, and still conceive. So as long as you're doing it every day around that time, you're not going to miss it and it would be fine.
Is it true that endo patients tend to have thick lining?
Oh, that's interesting. I've never heard of that before. I don't know that that's true. I've never seen that. Having said that, there are differences in estrogen and progesterone receptors in endo patients. So it's very possible that something like that could happen, but I've never seen that. That's one I'd actually have to look up. So great question, but I've never seen that before. And certainly in our endo patients, that's not something I encounter on a regular basis.
If one does ovulate regularly, blood work where it needs to be, and thickening linings well naturally, but FET doesn't work, would you go for the medicated FET or repeat natural?
Yeah, so there are a lot of varying studies on this, but the majority of the studies that I've read suggest that the letrozole cycle has a higher success rate than a natural cycle, and then natural is a higher success rate than the hormone replacement cycle. So we don't do any hormone replacement cycles. We do letrozole cycles, sometimes with a minimal amount of added estrogen, but very minimal compared to a hormone replacement cycle. Or we're doing a straight letrozole cycle on its own. I'll occasionally do a natural if the patient requests it. So yes, if you failed a cycle before, the first thing to look at is, was it the embryo, was it the transfer, or was it something about you? And then once you've determined that, if it is something about you or your lining, then addressing that can certainly be important. And we would start with the letrozole protocol, but usually I need to know a lot of details about the patient. So do you have endometriosis? Do you have PCOS where your sugar is optimized? Was your thyroid optimized? Did you have the right vitamins on board? Did you have the right supplements on board? Were you taking melatonin? So there's a lot of different features that go into it that are important to maximizing the success.
Can a man at 52 still produce good sperm with lifestyle change, or would the sperm be bad because of the age?
Well, from the standpoint of good or bad, it's still going to have reasonable quality. There is an increase in sperm DNA fragmentation with male age, so that's something that needs to be assessed, but frequency of ejaculation can correct that to a significant degree. The other part that's important is that regardless of how good or bad the sperm is, you are going to see an increase in your risk of probably genetically abnormal embryos and the risk of autism. So that's something you can't work around, but the sperm will still be good enough quality to help with a conception.
Have you had success rates with IUI with a mid-40 age group?
Yeah, I have. We all have. So in that regard, I think everyone will tell you yes, but the answer is the success rates are very low. If you look at the European data or even Chinese data, the suggestion is that over 3 tries, overall, you're looking at around a 15% live birth rate with 3 tries of doing it, all combined together statistically. So it's not very robust. It's quite a low success rate overall. It's possible, but it's not something we kind of push for people. We give them their options, and if that's what they choose, that's what they choose. But it's not something I would routinely pursue for patients.
If division of sperm egg stops after day 3 or slows, could this be an issue with sperm? If so, what could be some of the issues?
Yeah, so it really depends on who you ask. My embryologist firmly believes that the first 3 days is most likely related to the sperm, and then after that, it's the egg. I've heard the exact opposite from other people, so it is kind of hard to know, but I think it does make sense that the first few days is likely related to the sperm, and then after that, it's the egg. So if it's after the first 3 days that you're having problems, that may be more of an egg issue than a sperm issue. So that's something where I would want to look at the sperm. Having said that, it could be the culture conditions in the lab. It could be, the egg quality. It could be the sperm quality. It could be DNA fragmentation in the sperm. There's a lot that goes into this, so we don't always know.
Thoughts on supplements for sperm quality, NAC, arginine, etc.
Yeah, so there is overwhelming data now that those things do provide some benefit. It's not going to make or break any specific case. You're not going to go from having terrible sperm to having amazing sperm or from failure to success, but they can measure changes in the quality of the sperm from people that use supplements. So it is a very reasonable approach to things, and it's certainly harmless as long as you don't overdo it. You can actually overdo it. You can actually take too many supplements and cause something called reductive damage. But for people who have, sort of risk factors, so they're smokers, drinkers, drug users, they have, obesity, they have bad diets, that kind of thing, there can be improvements with the vitamins, but only if you're also correcting those other things. So for example, if you're a smoker and you continue smoking but taking the vitamins, you're wasting your time and money. It's not going to work. You have to stop smoking and take the vitamins, and then that will correct the problem.
My doc gave me Vizan for dealing with endo. I gained my weight a lot after taking 3 cycles of IVF, and after that I used Clomid and Letrozole.
Okay.
Yeah, that's on. That's the question.
Yeah. So Bizan is a progesterone and or a progestin, I should say, and it does cause weight gain. All progestins cause weight gain. In fact, for patients that are severely anorexic, we actually give them a specific type of progestin to make them gain weight. So it is a side effect. And some women will gain weight when they're doing IVF. Not all women, but some women will gain weight. As I always say, despite the multi-gajillion dollar weight loss industry, it's just math. It's input and output. And if you watch the true experts on this, they'll all tell you the honest answer. In fact, I just had a discussion with the U.S. plastic surgeon who was telling me this as well. He said it's kind of laughable what they see because despite what everybody thinks, it's just pure math. If you take in less calories than you burn off, it's biologically impossible not to lose weight. You just have to have a calorie deficit, as they call it. So if you take in 1,500 calories a day, which is a reasonable, intake, and you burn off 2,500 through normal daily activities and exercise, you're going to lose weight. It's biologically impossible not to. So maintaining weight or maintaining your physique during fertility treatment is possible. You just have to make sure that you're not overdoing the calorie intake and that you're adjusting with your calorie burn.
Can scar tissue found on hysteroscopy prevent implantation of cause issues with maintaining a pregnancy, waiting on a surgical hysteroscopy?
Yeah, for sure. I mean, we know very well that scar tissue in the uterus increases the risks of miscarriage, failure. It makes it quite difficult, in fact, and sometimes can prevent pregnancy entirely. So yes, if you have what's called Asherman syndrome, which is scarring in the uterus, it can be a very significant factor in fertility.
Hello. What are the advantages and disadvantages of medicated FET?
Well, as we said earlier in the show, a medicated FET has the lowest chance of success and the highest chance of miscarriage based on current data and findings. So we generally recommend that you avoid doing a medicated FET. Now, when I say medicated, we're talking about the traditional hormone replacement. So it's take estrogen, usually at fairly high doses, and then take progesterone, and then you're, doing your transfer. Natural is better, so you allow your natural egg to release, and then you supplement with progesterone. The progesterone's mandatory. And then letrozole is even better than natural. So you take letrozole, watch for the lining to thicken. If it's not thickening, you can use a tiny bit of estrogen. And then once you've got to the right stage, you start your progesterone, and then you use the progesterone, and off you go.
7 first trimester miscarriages with euploid embryos. Wow. The last 3 transfers on an RI protocol. What's next?
Contact me. That's something where it would make no sense. There's obviously something wrong, and we would want to know what that something was. So for sure, contact me, because you need a consult. There's obviously something somebody missed. So we would check your microbiome. We would check the genetics of you and your partner. We would look at his sperm DNA fragmentation. What are your habits like? What's your physique like? Where are your vitamin levels at? Where are your stress levels at? Immune issues, all of that. I mean, being on an RI protocol, which is a reproductive immunology protocol, is great, but it has to be appropriate too. Some people just go on things without knowing if they actually have the findings necessary for those. So for example, we use intralipids for lots of patients, but it's not necessarily indicated for every patient. So if you don't know what you're treating and you just randomly assign things to people or prescribe things to people, you can end up with no benefit to that use. So making sure you've had a very thorough evaluation is the key. I would tell you, I think it's absurd that you've had that many transfers and someone hasn't kind of hit the brakes and said, let's have a look at this, or even let's get a second opinion. I mean, certainly I have zero shame in these kinds of issues. So I only care about my patient's success. So if I had failed that many times, I would be asking for backup or assistance for sure. Yeah.
Oh, thank you for the informative show. What are recommendations regarding sex and resistance training after frozen embryo transfer? Thank you both for all you do.
Well, thank you for watching, and you're welcome on behalf of both of us. Sex is fine. There's no problems with sex. Tell people not to swing from the proverbial chandelier. So take it easy, but there's no issues with having sex before, during, or after. Those are all fine. With regards to resistance training, I would take it pretty easy. You don't want to be doing anything like sort of very strenuous or difficult or challenging after an FET. You have to remember that if you're doing something strenuous, your blood flow is going to your muscles and it's drawing away from your uterus. You want to minimize that. You also don't want to be building up a ton of lactic acid when you're trying to get pregnant. So, a reasonable amount of exercise is fine. Would I be training for the Tough Mudder? No.
Our 2 PGTA embryos were made when I was 42 and a half, before I found out about stage 3 endo. Already excised, even if they are normal, do they have a lower chance of implantation success?
They do, because you never fully get rid of the endo. So we would generally recommend doing an endo protocol. And then the other problem is that studies now show that age does have a factor or play a factor in patients who have genetically normal embryos. So if you were 35 and you had a genetically normal embryo, your chances of success are higher than if you're, say, 42, as you mentioned, and you have a genetically normal embryo. So there is a decrease or a decrement in your success rates when you are older. So that's something that needs to be looked at, but I would still strongly promote a endo protocol, and we now include a bit of an immune protocol in our endo protocol often as well. Okay, so it's Gardnerella and low lactobacillus. So the metronidazole should be sufficient to kill off the Gardnerella. You and your partner should both be using it. And then on top of that, the major issue is refilling the lactobacillus, which is the most important part of the microbiome. So you should be doing oral and vaginal probiotics, and then make sure that you're taking flagyl, which is metronidazole. We would normally recommend somewhere between 2 to 3 weeks to really fully eradicate things, and then make sure you get retested, which is really important.
What is the optimal lining thickness for FET?
Yeah, so the studies show that the minimum is 7. We really like a minimum of 8. We're occasionally willing to take like a mid to high 7, and then we don't like it going above about 12 or 13. So somewhere between that 8 to 13 is the sweet spot.
I keep hearing fertility specialists say that losing 5% of body fat will help regulate your cycle. And those with PCOS specifically, is this true?
Yeah, absolutely. It's true. There's actually studies specifically in the PCOS group that if you lose just 5% of your body, you will actually improve your outcomes, not just in terms of ovulation, but actually in terms of success with conceiving. So that is something we always advocate for with our patients.
Is a hysteroscopy beneficial for a fresh transfer 1 week before I start my IVF cycle?
Not unless you have something wrong. There's a lot of surgery that happens in the fertility world that I still don't understand the rationale behind. And I think it's almost always in the US because they can bill so much for it. So everybody should be getting a saline infusion sonohystogram before they do any kind of fertility treatment to make sure that the uterus is normal. If your SIS is normal, there's absolutely zero indication to do a hysteroscopy. And an SIS is essentially harmless and easy and requires no anesthetic, whereas hysteroscopy requires some type of anesthetic, usually unless it's just the kind where you're just looking, which is useless. So if it's just a diagnostic hysteroscopy, that's of no value. If it's operative hysteroscopy, you're going to require some kind of anesthesia. And so bottom line with both of those is that you need to make sure that you are getting it for an indication. If it's just random to see what's going on, that doesn't make any sense. And it's an egregious waste of money. If you're going to a fertility center that's promoting that, you have to be questioning why. What's the rationale behind doing a hysteroscopy that has no basis in any kind of biology, pathology, scientific rationale? There's no benefit. Not over a saline infusion sonohystogram. You do need some kind of uterine evaluation, but you don't need one that demonstrates, hysteroscopy first. I would never do that for a patient, like literally ever. There's no reason to do that. The only time I would ever do that is in somebody that couldn't tolerate being awake during an SIS. And then sure, you could knock them out and do a hysteroscopy instead, but that's going to be a super rare group.
Is there a BMI restriction at your clinic? If so, what is it and why?
So we strongly discourage patients from trying to conceive when their BMI is over 40. And the reason for that is that the risks of pregnancy, the risks of complications, and the risks of failure are just all way too high. So when I say risk of pregnancy, I mean things like miscarriage, bleeding, hypertension, preeclampsia, diabetes, cesarean section with catastrophic wound complications, the risks of things related to blood clots, heart disease, cardiomyopathy. All of these things are drastically increased in women whose body mass index is in that kind of severely obese category. So we try desperately to avoid it. Now, age does play a role. So if you're under 38, we will insist you bring down your weight first. If you're over 38, we will caution you strongly about your risks and benefits. But the data supports the fact that over 38, you actually have to lose a lot of weight to make enough of a difference. And we've actually reviewed that on the show twice now. We have 2 separate videos that basically showed the same thing. So, if you are in that category and your age is over 38, but weight is a factor, you need to make embryos. When and how we transfer them, that's a different story. But you need to make your embryos as quickly as you possibly can.
Which antibiotics are usually prescribed for chronic endometriosis?
Yeah, so I'm not a believer in doing blind treatment of endometritis, and I kind of would vehemently and passionately argue against the places that do just randomly treat endometritis. I just got a message from someone this morning asking about treatment of endometritis with doxycycline, and doxycycline only covers a few of the bacteria that traditionally cause endometritis. So it's not appropriate treatment. You have to actually know which bacteria you are treating and then treat those bacteria. You cannot just treat endometritis blindly. So you need a company that can actually diagnose which bacteria you have and then appropriately target those bacteria, because Gardnerella, which was asked earlier in the show, is only susceptible to clindamycin and metronidazole. It's not susceptible to doxycycline. So if somebody just gives you doxy and they don't give you the other one and your diagnosis is actually excess Gardnerella, it's not going to work. You're actually going to make it worse potentially. So we only believe in doing targeted therapy of endometritis, and that means getting a diagnosis of which bacteria are there first, and then pursuing the actual treatment using targeted antibiotics that are going to specifically kill the bacteria you have.
If my first untested FET works, how likely do you think my second FET will work?
That is probably the best crystal ball question I've had in a long time. Yeah, there's no way to know that. I mean, it depends on a million factors, mainly your age when you made your embryos. But I would say your chances are quite good, but, super vague, right? I can't answer the specifics because I don't know anything about you.
Dr. V, are there any circumstances in which you transfer two euploid embryos? If one doesn't stick, is that harmful to the other? Is the likelihood of twins with transferring two euploids high? Thanks.
Yeah, so we tried desperately not to do that. If you transfer two euploid embryos, according to the studies, you have as high as a 70% chance of ending up with twins, and twins is automatically a high-risk pregnancy. So we tried very, very hard to avoid doing that. If a patient insists for a variety of reasons, they have to accept the risk to the mom. So those are things like preeclampsia, hospitalization, bleeding, diabetes, preterm labor, preterm delivery, all of those things. The risks to the babies, which are risks of complications with preterm labor and delivery. So essentially, those are the babies that are going to come early, and depending on how early they come, they can have a lot of complications. And then there's also the risks of having complications associated with social issues. So there's an 80% divorce rate with twins. The last time I did a double embryo transfer into patients with euploid embryos, I actually ended up with a problem with having one of them split into identical twins. And because of that, she now has triplets. So she has a set of identical twins and then a fraternal triplet, which is a big problem. So that is a super high risk pregnancy. And I had to refer her on to be assessed.
How would you proceed with a patient that has presumed endo and signs of adeno on a transvaginal ultrasound before transferring embryos?
Yeah, so we would use an endo or an adeno protocol, which basically involves suppression therapy like Lupron and letrozole. And then we use lots of supplements, and then you need high dose progesterone. As far as the other part of it, it's a question mark of surgery. So if you haven't had surgery, we advocate for the surgery. If you have, then you don't need the surgery again. We would just go straight into suppression.
Ari doesn't believe my results from Fertilizing and won't prescribe antibiotics.
Wow.
Any tips on how to bring it up again? My results showed urea plasma and staphylococcus.
Staphylococcus. Yeah. So, I guess my suggestion would be get a different RE. If they're not believing in biology, then they don't understand it, which is concerning to me. The way that Fertilizing analyzes the bacteria is by a PCR. It literally can't be there unless it's there. So to me, that's very worrisome that your RE doesn't believe in it. So if you've got someone that's that stubborn, then and doesn't understand basic biological science, you need a different RE.
Dr. V, there are any circumstances in which you transfer to you? Oh, I did that one.
Yeah.
I think, like little twins. Yeah.
You're going to nowadays.
What's that?
You're going to edit all of these out.
Yeah. But this will be the only live that's going to be flawless.
Yeah.
Is there any testing that can be done for people with autoimmune disorder trying to conceive? I've had 5 failed IUIs and I failed IVF cycle.
Wow. First of all, I'm sorry you're going through all of that. Those are the ones where we would want to consult for sure to go over things with you. But yeah, there are lots of tests that can be done. There's reproductive immunology tests we would strongly advise, as well as other testing that should be done for you and your partner. So yeah, there's lots that can be done to evaluate, but we would need to see you and work that out.
Can uterus scar tissue after a polyectomy? If so, how can you mitigate against this? Are implantation success rates lower in women who have a polyectomy in relation to those who have not?
Yeah. So if you've had a polypectomy, you can cause scarring in the uterus. It's not super common, but it depends on how aggressive the polypectomy was hysteroscopically and some of the factors about the patient. Is there an infection? Was there an infection? Is the patient very thin? Do they have low estrogen levels or a really atrophic lining to begin with? Those sorts of things can contribute to scarring. If you have scarring, it will definitely decrease your success rates. How do you avoid it? You can give estrogen after the procedure if they're like a low estrogen patient, typically someone older or very thin. And then in a worst case scenario, there are balloons that you can place in the uterus to kind of keep it apart so it can't scar back down together again. So those are things that we do commonly.
What do you think of MitoScore?
We have videos on MitoScore. So it was really big when it first came out. It's no longer really big because the data just didn't support it. So we don't even pay attention to that anymore. It's kind of useless at this stage. It's basically being disproven. So no one's doing that as far as I know.
2 years before I did 3 IVF cycles, says I don't know what but is, all are failed because of endometriosis. The egg quality was poor and DOR.
Wow. I would want to talk to you and see it. That's certainly a situation in which we would at least discuss the benefits of doing donor egg with you, but you'd have to kind of go over it and see what you wanted for you. So, that's one where you have to be prepared to have the donor egg discussion. There are ways to succeed with you, but it would often take a lot of tries. And if that was 3 years ago and you had DOR then, it's going to be particularly difficult now. So you'd have to be prepared for kind of a challenging go at it all.
Would you do both vaginal and PAO injections in a modified natural cycle FET? My clinic doesn't test for progesterone. My third FET led to my first plus with PIO only. Should I ask my doc to add pessaries?
Yeah, so it's unquestionable that the combination is best. There is a lot of data on that now. So I would strongly suggest using both. However, if you're doing a natural cycle and you're going to release an egg, you're going to overshoot your progesterone levels because as your natural egg and progesterone levels rise, you need to titrate down the one that we're giving you or else you'll get too high a level. So you do need to work with a center that measures your levels. Otherwise, you can end up on birth control.
If you ovulate during an FET transfer and still trigger, does that mean you need less progesterone even with endo? Thanks.
It does. Potentially, you have to measure levels to make sure you're hitting the right targets. But yes, your body's going to produce some, so you don't need to take as much traditionally.
I'm trying to conceive with the endo in my right ovary. My fallopian tubes are clear, uterus is clear, but I am struggling.
Well, endo makes it difficult. So you have to meet an RE and discuss the value of the various approaches, whether it's natural supplements, because there are some that you can use, medications that can be helpful, insemination can be helpful, IVF can be helpful, and then there's surgery as an option as well. So, all of those are possibilities. The European Society for Hormones and Reproductive Endocrinology and the British Fertility Society have guidelines. In fact, the British Fertility Society just released them for us to review before they actually publish them, showing that surgery may be beneficial for endo patients, which unfortunately Canadian guidelines don't delve into, and I disagreed with that when they published them. So I do think that it can be beneficial and has to be considered.
And wrapping up near the end here, what do you recommend to help increase your chances for successful egg retrieval or transfer?
Oh God, that's a big question. That's a wrap-up question. Yeah, I mean, healthy diet, lots of supplements, make sure you're exercising, keep your stress level low. That's kind of consistent throughout the whole thing. Make sure that you are having intercourse prior. Make sure you're working with an RE that knows what they're doing and doesn't disbelieve scientific truths like PCR results from Fertilizing. And then make sure for your FET that you're following a either natural cycle or modified natural or letrozole protocol. Make sure that you're getting your progesterone, both vaginal and injectable. Make sure you're on all the right supplements. Continue having intercourse again. So yeah, there's a lot of different things that go into it. It's not a quick kind of internet answer, but yeah, there's a tremendous amount that goes into success.
And that seems to have cleared the backlog, Dr. Victor.
Awesome. Well, thank you so much for joining us again this week. We really appreciate having you. Sorry we couldn't do a live, but I needed some quality time with the family. And we will see you next week on Fertility Fact